Can everybody hear me? So are we ready to get going? It's 12:01, or do we want to? Okay, good. I got the thumbs up to go. So I've got a couple of announcements to make before we get started with the main presentation. One thing is to please be sure to sign in with your full name and not just your phone number today. This helps us to match up surveys and also member attendance. If you're watching the webinar via YouTube, this is a new thing for us. Be sure to hit the subscribe button while you're in that app or on the web. Also, to all of our other members, please take time to go out to read our YouTube channel or to view our YouTube channel and subscribe. That will also help us to build that. So here's something exciting that we want to announce. We have partnered with MGMA Kansas has partnered with Midwest MediWaste, and it's going to attempt to boost our membership in our organization. We're joining forces to offer eight $50 memberships to new members only on a first come, first served basis. And so what that looks like, the stipulation to that is, trying to scroll up here. The stipulation is that they must be a new member to our organization and must meet the requirements of membership. If you have someone in your organization who would benefit, or if you know of a new administrator in a clinic near you, please help us both out by going out to or contacting us to let us know if you have a new member. Limit one new member per organization though. So it's one new member per organization. We had 8 of these, but we currently have 7. The first 7 to respond to Phil today with the name, business title, and company will be the winners and will be announced at our upcoming webinars. We would like to announce that of those 8, our first winner is Lisa Greer from Beloit Medical Center. So congratulations to Lisa. And so now onto without much further ado, onto our main presentation, Miss Brenda Edwards. And Brenda, I'm not going to read the alphabet soup behind your name, but we know she is the guru in all things coding. Director of Auditing at Crossroads Health Resources. She'll be reviewing the upcoming 2021 E&M changes, and we'll learn the changes on how documentation will change and what codes will be affected in this webinar today. Brenda's been involved in healthcare arena for over 30 years with experience in chart audit, coding, billing, education, consulting, practice management, and compliance, and worked closely with all the practices and providers and residency programs to ensure documentation is compliant and accurate. So welcome, Brenda.
Hello, how are you? I see lots of familiar names again on here. Oops, hold on, I about hit the wrong button. I about left instead of shared my screen. Okay, can you see my screen okay, Phil or Abby or John?
Yes, we can see your screen just fine.
Okay, so has anybody not heard that we have some serious changes coming very soon, in about a little over a month? Oh, I need to put my chat box up so I can talk with you guys too. There are significant changes, and we're going to go through these today. I'm going to keep the chat box open, so if you have questions as I'm going, feel free to chat and I'll watch it and answer you. Okay, let me get all set up here and then we'll be good to go. I just want to say hi to everybody that I see here. It's good. Okay, let's get rolling. So this has been one of my Bibles. I can't believe I don't have it in front of me. Where did it go? The E&M changes that were published in January. This document is from the AMA, as you can see. I can either send it to Phil to share with everybody, or you can go out on AMA's website and obtain it. This is where all the answers come from. Now, keep in mind that this was published early this year. There have been some changes. We have a definite code for the 99XXX. So also some of the times changed with that. So Where's the link to print the PowerPoint, Phil? On the website?
Yes, it is on the website. If they go to www.mgmaks.org and go to the links portion or go to the resources portion under documents, it is down at the bottom under Brenda Edwards slide documents. Now, you must be a member in order to be able to log in and access those documents, though, or to access those PowerPoint slides.
Okay, thank you. So if you want, Phil, I can send you these two documents, the one I have up right now, as well as the purple shaded grid, and that's our new medical decision-making table. So is it, okay?
We can load it in then.
Okay. So is it apples to apples? No. If anybody has been investigating the E&M changes, we're going to have some significant changes. Remember, though, that these only apply to 99202 through 99215. It will not affect a lot of the other code set. So on the left-hand side of the screen is the current E&M audit tool, the one that I use a lot. I know Tracy Bird has used it over the years. Excuse me. It has all of the history, exam, medical decision-making components. When we start January 1st for that given code set, we will no longer have to score the history and exam. It will strictly be medical decision-making, which is that purple grid. And I have a bigger version of it we're going to look at to be able to drill down. Overview of the changes. Major revisions. 99201 is eliminated. And that is because when we only score based on medical decision-making, a 99201 and a 99202 only require straightforward medical decision-making. So there's no point in having a repetitive code. Now, let's stop and think about this. For those of you that audit, and if anybody wants to type in the chat box what your feelings are, I've had a number of people asking, well, how are we going to compare our audit next year? If we're looking at apples to apples, we're not going to have any 99201s to compare to next year. So what I'm trying to say, I said it backwards, is our lowest level code next year will be a 99202. If we make a comparison of how frequently that code is used for any given provider, it's going to look inflated at the 99202 because we won't have a 01 to compare against. So has anybody considered that, thought about it, worried about it? Anybody want to chat to me? I'll keep going while I wait for anybody to chime in. Now, when we say that history and exam are not going to be used to determine the level, that does not mean providers are not supposed to document it. It will still need a medically appropriate history and exam documented. So if you think about it from a legal standpoint, that note has to support the service, whatever is done. And if we just have a portion of a note instead of that full narrative, it's not going to support the service. The E&M will be determined by the medical decision-making or total time spent performing the service on the day of the encounter. So now our provider doesn't have to just spend that face-to-face counseling coordination of care time. They can spend time before the visit and after the visit, as long as it's on the same calendar day. And then all of that time can be added together. I did this presentation a couple of different times now for physicians. So they always say, so all I have to do is document time now. No, you still have to be able to see the medical necessity in the visit. So time, another concern about time is when we look at a physician schedule for the day and we start billing all of these codes on time, including the pre and post work that is performed, we still have to meet the total number of hours that can possibly be used in a day. So payers are going to be watching that. WPS, I believe, already said that they're going to monitor that. No different than what we see now with counseling coordination of care. So just make sure your providers understand this is not a shortcut on documentation. You're still going to document as you do your service. We don't want to see anything less. But what is used for scoring, we don't have to use all that review of systems and past family and social history. So when we meet with providers and say, well, you missed your 99204 because you didn't have a past history, we're not going to have to worry about that in the future. They document what is relevant to them. Okay, key changes. Time is being redefined. The time statement we have is typical face-to-face time for 2021 for this given code set. It will be total time spent on the day of the encounter. Other key changes, there's some language change in our medical decision-making categories, a little clarification, and that's in the green at the bottom of the slide. So number and complexity of problems addressed, amount and or complexity of data to be reviewed and analyzed, and then risk complications and or morbidity or mortality of patient management. The other thing we are going to see, and if you guys have your CPT books already, I'm jealous because I'm still waiting for mine, but we're going to have an expansion of guidelines in the evaluation and management section. So not only will we have guidance for our traditional services that we're used to seeing, we're now going to have another section that's going to define how we do time and medical decision-making tables, everything related to just this code set. All right, so we have, for over 25 years, drilled it in. It's history, exam, medical decision-making, and we need to worry about, is it a new patient or an established patient? Because if it's a new patient, they all have to meet that level. In 2021 and beyond, again, I can't say it enough, it's just 99202 to 215. It will be medical decision-making or time, but you have to be able to see that medical necessity. So when we look at a E&M code today, everything that's grayed out is what we're currently seeing. So for this example, 99203, the three key components of the level of history, exam, medical decision-making, and then there's a narrative about counseling coordination of care and the level of severity. All of that that's gray and crossed out will no longer be there. Instead, it'll be a medically appropriate history and or examination and low-level medical decision-making. And then the other add-on will be when using time for code selection. So for this given code, 30 to 44 minutes of total time spent on the day of the encounter. So I'll answer this before anybody asks. Does that total time include staff time? And the answer is no. Total time is of the provider rendering the service. The time it takes for the MA or whoever it is to room the patient, the nursing time, none of that is counted now and it can't be counted in the future. So history and or exam. Let me just summarize this. Look at the second bullet. The extent of history and physical examination is not an element in selection of office or other outpatient services. From a medical legal standpoint, providers' documentation should reflect accurately the details of the encounter, so no change from what is currently expected. I always say that documentation is, each visit is like a story. We need a chief complaint to know why they're coming in. We need a little history to start the story, and then we need a close to the story at the end, and that'll be our decision making. So we still want to see that story in their documentation. Some caveats. The concept of medical decision making does not apply to 99211. Michelle wants to know, can they document no change in history? If it's relevant and it helps support the service, if it Now, so the question will come up is, well, what did the history look like before? So if you maybe reference no change in history from X date of service, that might be a little better. Anybody have any thoughts that want to chat in for it? Okay, so 99211, no medical decision making in that, and you'll notice that when we get to our grid that it's not applicable. Shared medical decision making involves eliciting family and or patient and or family preferences, patient and or family education, explaining risks and benefits of management options. Medical decision making may be impacted by role and management responsibility, and we'll look at that in a few slides. When the physician or healthcare professional is reporting a separate CPT code that includes interpretation and report, you're not going to bill or you're not going to count that time, that effort in your medical decision making when it has its own code that will be billed out separately. So you want to back that out. Okay, so here's what we have, our medical decision-making table. We have, I've shown you in comparison at the top of the slide what our current language is, and then what it will be in the purple shaded area. And that is the number and complexity of problems addressed, amount and or complexity of data to be reviewed and analyzed, and then the third one, risk of complications and or morbidity or mortality of patient management. We're going to break down each of those columns and talk through them a little bit closer. If you're just kind of doing a quick look, one big thing that I am so happy about, the new patient and established patient, level 2, 3, 4, 5, they have the same criteria. So we're not going to have to worry, is it a 99203 and needs 3 elements, or a 99213 and needs 2 elements of history, exam, medical decision making. All we need to know is that a level 3 is low decision making, a level 4 is moderate, a level 5 is high. I think that is going to make life much easier. Anybody agree? You guys just don't want to interact with me today, do you? Okay, so we're going to start by looking at the number and complexity of problems addressed. So as I mentioned, the 99211 does not have to meet any of the medical decision-making requirements. 99212 is straightforward medical decision-making. Oh, good, you guys are finally talking to me. New guidelines are much easier for providers to understand. Yes, they are, but they overthink them. Okay, so 99211 is a self-limited or minor problem. 992, well, a level 3, let's just say it easily, is going to be 2 or more self-limited or minor problems, a stable chronic illness, an acute uncomplicated illness or injury. Suze, yes, you can still bill a 99211 for nurse visit. This column should look very familiar. It is virtually the same until we get to the high decision-making category. So looking at our moderate, 1 or more chronic illnesses with exacerbation, progression, or side effect of treatments, 2 or more chronic stables, an undiagnosed new problem with uncertain prognosis, an acute illness with systemic symptoms, and an acute complicated injury. Then when we get to the high category, they're going to be the same. The abrupt change in neurological status is not a separate bullet, but it is included in the 2 that are here. 1 or more chronic illnesses with severe exacerbation, progression, or side effect of treatment. And then acute or chronic illness or injury that poses a threat to life or bodily function. So multiple new or established conditions may be addressed at the same time and may affect medical decision-making. So something to keep in mind is MEET. Remember MEAT, monitor, evaluate, assess, treat. That's what we use in risk adjustment world, but it's just good documentation habits. So if a provider is documenting that they are monitoring, evaluating, assessing, or treating a condition, it's likely going to count towards their medical decision-making. But when they just simply list diagnoses or say diabetes followed by hypertension followed by, there's no meat occurring. Symptoms may cluster around a specific diagnosis. Each symptom is not necessarily a unique condition. So, for example, sinus infection with nasal drainage, cough, those symptoms are a part of the disease process, so we're not going to count them each as a unique condition. Comorbidities, underlying diseases, and this is kind of what I just touched on, are not considered in and of themselves, are not considered in selecting the E&M unless they are addressed and their presence increases the amount and or complexity of data to be reviewed and analyzed, or the risk of complications and or morbidity or mortality of the patient management. So again, simply listing diagnoses without giving any further indication would not be sufficient. Final diagnosis for a condition does not in itself determine the complexity or risk. Extensive evaluation may be required to reach the conclusion that signs or symptoms do not represent a highly morbid condition. I always go back to a visit I had one time, a discussion after a chart review that I had performed with the cardiologist. And he was using higher medical decision-making for some symptoms. And I'm not clinical at all. And I made the comment of, you know, well, when you've got dizziness, you wouldn't expect it to be as intensive as some of these more severe conditions. And I will never forget this. He said, it is so much easier for us to know what to do with the given condition versus signs and symptoms, because it could be anything. And I've always considered that, you know, it's not my call. I can look at an audit tool and tell you how it looks on that, but that clinical impression comes from our provider. And so we need to make sure that we understand their thought process. Multiple problems of a lower severity may in aggregate create a higher risk due to interaction. So maybe, you know, we always use diabetes because it interacts with everything. Maybe we have some lower conditions and we have diabetes, and the interactions may make it higher risk. And so the key there, document that. Tell us the story. We need to know the thought process. Think in ink. What's going on up here needs to end up in your document. Problems addressed or managed when it's evaluated or treated at the encounter. So that's what I mentioned earlier as well. A notation, another professional is managing the problem without additional assessment or care coordination does not qualify as being addressed or managed by that provider reporting the service. Okay, elements of medical decision-making part 2. Now we're going to look at the amount and or complexity of data to be reviewed and analyzed. First thing, there's an asterisk at the top. Each unique test, order, or document contributes to the combination of 2 or more, combination of 3 in category 1 below. I think this is the most confusing column of all of our decision-making table. So let's walk through it. We're again at level 2, 3, or 1, 2, 3, 4, 5. So level 1 doesn't apply. Level 2 is minimal or none. Level 3 is limited. So must meet the requirements of at least one of the 2 categories. So we have category 1 for tests and documents, and category 2 assessment requiring independent historian. So our category 1, you need 2 of the following: review of prior external notes from each unique source, review of results of each unique test, or ordering of each unique test. Now, this is significant because historically, when we would look at lab or x-ray, we would give them 1 credit for no matter how many labs were obtained or x-rays, but now they can get credit for each unique lab they order. Now, if it's a panel, you get 1 point for a panel. It's each unique. So the most we need in this category is 2 items. So keep that in mind. The category 2 assessment requiring an independent historian. Okay. Then when we move down to moderate, level 4, we have the category 1, category 2. Now we have a category 3. And we still need to meet 1 of the 3 categories. So The category 1 now has a new addition of assessment requiring an independent historian. Category 2 is an independent interpretation of tests. And category 3 is discussion of management or test interpretation. And it does indicate there with an external physician, other qualified healthcare professional, appropriate source. And again, if you're reporting a code separately there, such as the interprofessional consult codes, you do not count it here. Then when we move to level 5, it's the same thing as the level 4 categories. The difference is you need 2 of the 3 categories met instead of just 1. What do you guys think about all of that? I'll keep going while you guys let me know. So here's some definitions. A test, imaging, laboratory, psychometric, or physiologic data. So here's where I just mentioned a clinical lab panel is considered a single test. Differentiation between single or multiple unique tests is how is it defined in CPT? Please define independent historian. We're going to get to that on the next slide. External records, communications and or test results are from an external physician, other qualified healthcare professional, facility, or healthcare organization. External physician or qualified healthcare professional is one who is not in the same group practice or is a different specialty or subspecialty, including licensed professionals that are practicing independently. It may also be a facility, organizational provider like a hospital, nursing facility, or home health care agency. Tracy, you had to ask that question, didn't you? Is ordering and reviewing tests, does that count for 2 in that category? There has been a lot of back and forth on how to count that. We've been trying to get WPS to define that for us. If you read it, right now we're being conservative and saying if you're ordering and reviewing it on the same day, it's counted together. If you're ordering on one day and reviewing another day, pretty much you're going to get credit once. But stay tuned. We're hoping to get further clarification on that. And if anybody is on here and has heard anything from WPS or AMA clarifying it further, feel free to put it in the chat box. An independent historian. This is an individual, so it can be parent, guardian, surrogate, spouse, witness, who provides a history in addition to a history provided by the patient who is unable to provide a complete or reliable history, or because a confirmatory history is judged to be necessary. In the case where there may be a conflict or poor communication between multiple historians and more than one historian is needed, the independent historian definition is met. So the question, does that mean a parent of a pediatric child is an independent historian? And we have gotten the answer, yes, that is true. So, you know, I don't know that I really agree with that because that parent has always been the historian. But according to WPS, that is acceptable. Independent interpretation. This is going to be of an interpretation of a test where there is a CPT code and an interpretation or report is customary. Does not apply when the physician or healthcare professional is reporting the service or has previously reported the service for the patient. A form of interpretation should be documented, but does not have to conform to the usual standards of a complete report for the test. And then appropriate source. This one's interesting. For the purpose of discussion of management data element, an appropriate source includes professionals who are not healthcare professionals, but may be involved in the management of the patient. Lawyer, parole officer, case manager. It does not include discussion with family or informal caregivers. Okay, moving on to our risk category. And this one, it's much more simplified, but if you look at those first couple of categories, the 99211, it's not applicable. The level 2 is minimal risk of morbidity from additional diagnostic testing or treatment. And then low is low risk of morbidity from additional diagnostic testing or treatment. We don't have any examples that give us a little bit of lead. When we get to moderate, we do have moderate risk of morbidity from additional diagnostic testing or treatment, and some examples: prescription drug management. This one is not any further defined than prescription drug management, like we have now. Decision regarding minor or elective major surgery, the next two bullets. The first is with identified patient or procedure risk factors, and then the elective major surgery without identified patient or procedure risk factors. So that's a change, because in the past it's just been identified risk factors, and there was always a debate, well, is it the patient or the procedure? Now it's clearly defined, it's either one. Our last bullet is a new one: diagnosis or treatment significantly limited by social determinants of health. So back when we moved to ICD-10, we made a point of sharing that there are social determinants listed for specific diagnosis codes. We're also seeing that now in our medical decision making. So that could be the fact that the patient's housing, or I use this example of patients can't afford their medication, so they lower their dose on their own, and it is affected, affected because financially they can't afford that medicine in the correct dose. Ran through that with my dad not long ago. I said, why aren't you taking your medicine correctly? Well, I'm in the donut hole. Well, I don't care. It's not gonna make your health any better by not taking the right medicine dose. Our high risk of morbidity, these are all similar to what we're seeing currently. Drug therapy requiring intensive monitoring for toxicity. We're going to talk much more about that. Decision regarding elective major surgery with identified patient or procedure risk factors, and then decision regarding emergency major surgery, decision regarding hospitalization, decision not to resuscitate or to de-escalate care because of poor prognosis. Risk. So we're going to go through some more definitions now. Probability or consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. A couple of these bullets, I think you have to read them over and over and over for them to make them less confusing. A low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may be low risk. Definitions are based on usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. So what that is saying, I'm going to go back one slide. When we're looking at these minimal, low, moderate, high risk of morbidity, they're saying these are based on the usual behavior of that specialty. That third bullet, trained clinicians apply language such as high, medium, low, minimal, and do not require quantification for these definitions, though quantification may be provided when evidence-based medicine has established probabilities. How are we going to know how our providers interpret those? And the answer is we have to communicate with them. We have to find out what our providers look in that medical decision-making table and where they and their specialty would consider some of their conditions. For the purposes of medical decision-making, level of risk is based upon the consequences of the problem addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, hospitalization. So make sure your providers are documenting that the patient is not a candidate for a test or a surgery. Documenting that is also going to play into their total level of risk. Morbidity. I always have to think of Mortal Kombat. Mortal is life. Morbidity is the state of an illness or functional impairment. It's expected to be substantial duration. Function is limited. Quality of life is impaired. Organ damage may not be transient despite treatment. And then here's our definition: social determinants of health, economic and social conditions that influence the health of people and communities. So food, housing, as I mentioned, the medication. Okay, let's talk drug therapy for intensive monitoring for toxicity. A drug that requires intensive monitoring is a therapeutic agent that has the potential to cause serious morbidity or death. It is performed to for the assessment of adverse effects and not for the therapeutic efficacy. It should be what is generally accepted practice for that medication, but may be patient-specific in some cases. This next bullet is important. Intensive monitoring may be long or short-term. Long-term monitoring is not less than quarterly. Can be a lab test, physiologic test, or imaging, but not history or exam by itself. It affects the level of medical decision-making in which it is considered in the management of the patient. And then we've got a couple of examples at the bottom. Examples for monitoring for cytopenia in the use of an anti-neoplastic agent between dose cycles, or the short-term intensive monitoring of electrolytes and renal function in a patient who is undergoing diuresis. Examples that would not qualify: monitoring glucose levels during insulin therapy because that primary reason is therapeutic effect, or annual electrolyte renal function for a patient on a diuretic because it's annual, not quarterly. All right, any questions before we shift to time? Please remember, all of these changes are not going to affect hospital codes, outpatient, ER. It's just the 99202 to 215. Okay, I'm going to keep moving. Hey, everybody, make sure you subscribe to the YouTube channel. Time definitions is defined by the service descriptor. It requires a face-to-face encounter with the provider of service. Carolyn wants to know, what insurance does this affect? It affects every insurance that uses a CPT code. It is not CMS only. It is a definite change for next year. You cannot level based on history and exam any longer. Those requirements are all going to be changed. So Carolyn, the answer is everybody. And that's why I keep stressing, make sure like your hospitalists know if they're billing the hospital codes, this won't affect them. The ER codes, it will not affect. Are all payers required to go this route? I'm not going to say, Linda, definitively they're all required to, but there's not going to be an alternative. Even back like late summer when we kept hearing the next wave is coming of COVID, will they delay this? There's been no mention of delay. In fact, the only thing that was ever mentioned is the possibility of letting providers use current medical decision-making or next year's, and I haven't even heard that. I mean, everything is pointing to the fact of this is a go on January 1st, including work comp. Shirley, I think the difference with ICD-10 for work comp is there was still another code set. This code set goes into effect January 1st. So anyone using CPT codes, evaluation and management codes for outpatient office, it's going to affect. Okay, back to this slide. Time can be used to select a code, regardless if counseling coordination of care dominates the service. This is where our providers are going to have two hats. If they're seeing patients rounds in the hospital and they're seeing patients in the office, they still have to follow history exam, medical decision-making in the other locations, and time as well will be counseling coordination of care. It'll still be documented as it currently is. Eventually, all of the E&M codes are supposed to change over to this, but it's not going to happen all at once. Time describes the total time on the date of the encounter, face-to-face and non-face-to-face, spent by the provider of service. So again, people rooming the patient or the nursing or any other ancillary does not count in the time. What if your provider starts the encounter today and then finishes it up and closes it out tomorrow? That time cannot be used tomorrow. It's only on the calendar day. What does it include? It includes preparing to see the patient, reviewing tests that I call it, they're finally getting credit for all the stuff that we've always said, well, that's just part of what you do. But they're going to start being able to count that time. Obtaining, reviewing separately obtained history, performing medically appropriate exam and or evaluation, counseling and educating the patient, family, or caregiver, ordering medications, tests, and procedures. And now we're going to get into some that say when not separately reported. So if you can bill separately for a service, you do not count your time here. So referring, communicating with other healthcare professionals, the documenting clinical information in the electronic or other health record. Now, my caveat here is typical time it takes to document an EHR. You're not going to get extra time if you're not as proficient in a computer. It's typical time. Independently interpreting results, communicating results to the patient, family, or caregiver. Again, if you're billing separately for those, then you cannot count that time here. And then care coordination that's not separately reported. Oh, I missed a question up here. Blue Cross of Kansas has still not decided. To my knowledge, they're all moving forward. Okay, so here's our times. 99211, 7 minutes. You can see as you go up the code base, the specific times that are indicated. Just remember, it doesn't matter now if it is a newer established, if it's a level 2 visit, it's going to be low decision making. Level 3, moderate, and then moving up. Okay, here are the proposed RVUs. Now, I know there's a lot of rumblings, there's going to be cuts. Until we get the final physician fee schedule, we're not going to know what is going to happen, but this was what was proposed. And if you look at your level 2, 3, 4, 5 established patients, these are set to go up. Again, it'll be November. Well, we're in November now. It'll be sometime between now and the end of the year that we will hopefully have word if what that final RVU is going to look like. But also make sure your providers are aware that what they code as a level 3 this year may look like a level 2 or even a level 4 next year. Don't get hung up on the level as much as the when we get that final RVU, because if you look at it, 99212 is set to go up considerably. So just keep that in mind. And I've really not seen a lot of change, more so that they're able to get a higher level based on what they're doing. Please make sure that you're not, I always get this question, just tell me what to document so that I can get paid more. No, I don't do that. I tell you, these are the coding guidelines, and based on what you're currently documenting, this is what it looks like. Okay, we've got some, does the documentation for time need to state what the time was spent on, or can the provider state the total time? So best practice at this point is to outline what is included in that time. We don't have to have stopwatch. WPS has their frequently asked questions now that they have updated. That's another document that I can give to Phil to share with everybody, or you can go out to the WPS website. We all know how easy it is to find anything on there, but they have clarified some of this. I think Blue Cross is following the coding guidelines, but reimbursement are still not decided. Yeah, the reimbursement's what's up in the air. In an academic setting, is time based on the resident and or the supervising physician time. Are they billing a 99? Well, they are billing, yeah, the outpatient office visit. And I believe that it is, it's going to be considered the way it is now. Let me come back on that question though, and I will get a definitive answer for you. I don't want to say yes or no and be incorrect. Okay, now we're going to talk about our new prolonged service code 99417. And it is prolonged service, prolonged office or other outpatient E&M service beyond the minimum required time of the primary procedure, which has been selected using total time. Requiring total time with or without direct patient contact beyond the usual service on the date of the primary service, each 15 minutes of total time. This code is only to be used with 99205 and 99215. Okay, so of course, we're going to have two sets of rules right now. When you look at this in AMA's world and in CMS's world, they're very different. AMA wants you to have the floor time, the base time. CMS wants the ceiling, the high end of time. So when we look at this time element, if we're looking at a 99205 plus one additional unit of the 99417, the 15-minute increment. If they're less than 75 minutes, you're not going to be able to bill a 99417. If they have met 75 to 89 minutes, you can bill 1 unit. 90 to 104 minutes, 2 units, and then anything over 105 minutes will be a 99417 for each 15-minute increment. For 99215, it's less than 55 minutes is not separately billable. 55 to 69 minutes is 1 unit. 70 to 84 minutes is 2 units. And then 85 minutes or more is going to be 3 units. CMS, you need to add 15 minutes on top of this. Now, this will be clarified in the final rule. But as of right now, CMS looks at 60 to 74 minutes for the 99205. You have to add another 15 minutes on top of it before you can start billing a 99417. So as you can see here, 89 to 103 minutes will get 1 unit, 104 to 119 minutes, you can bill 2 units, and then over 120 minutes, it's going to be 3 units or whatever is appropriate for each 15-minute increment. For 99215, you have to have at least 69 minutes before you can bill that additional 99417, and then 84 to 99 minutes for 2 units and 100 minutes or more for 3 units. So as soon as we get the final information on this, we're hoping they come to an agreement and they all will view it the same way. This is a decision tree from Decision Health that is in one of their new publications. And the left-hand side are the CPT guidelines. The right-hand side are the proposed CMS guidelines. And as you can see, I put some green arrows for the CPT guidelines and some blue arrows for the CMS guidelines. This tree is the same except for those 4 boxes. And that is, are you reporting an office, other outpatient encounter based on time? The answer is yes. And then it splits off. Is the total time greater or equal to 75 minutes for the new patient, 55 minutes for the established patient under CPT? The change is under CMS. Is the total time for the day's encounter equal to or greater than 89 minutes for the new, 69 minutes for the established? So hopefully we'll have some clarification on that before too long. This is the question we all get. Just tell me what to document. Well, here's what you need to document. The HPI is going to help tell the story. Don't leave that off. Don't worry about counting bullets. You don't have to worry about 8, 9, 10 review of systems or 3 past family social histories or how much exam. Providers document what they feel is relevant. They do what is relevant in their service. New and established medical decision-making for a level 2 is straightforward. 3 is low. 4 is moderate. 5 is high. We don't have to worry about those 2 elements or 3 elements. Document an exam when it's medically necessary. Document to support your service. Tell the story, paint the picture, be graphic, and then update medical history when relevant. Do prolonged service codes replace add-on therapy codes? No, these are new codes that will only apply to 205, 215. Any other add-on codes have not been deleted. Okay, I have 9 minutes and some examples to run through. And this is really just look at the overall picture. Here's how it would review out today, and here's what it will look like as of January 1st. This is a female establishing care, and for a pre-op evaluation, she's having foot surgery. She's had a rupture of a capsule or a ligament. Most of the rest of this note is pretty good background history, so we don't want this part to go away. We want our providers to keep documenting this. No concerns today. She's in good health. She has a history of hypothyroidism, strong family history of hypothyroidism and hyperlipidemia, and then some preventive information at the bottom. This is the part that I think providers are going to be happy about, is we don't have to go through all of this every visit. They tell us what's relevant. They tell us of the review of systems, what is needed, and the exam as well. Now, from a coding auditing standpoint, we can pull a lot of great information out of the history and the exam. So you may find abnormal information listed in the exam or even review of systems, and that will help to support what we're finding in the assessment and plan. So this patient, foot pain, no contraindications, does not need any further cardiac workup. So you're looking for buzzwords, graphic words, detail words. No contraindications, no problems, normal EKG. Now, when we get down to hypothyroidism stable, they are going to refill a med and they're doing a lab test. So I would give credit for that. Same with the dyslipidemia. But look at number 5, 6. Depression stable, stay on current meds, and GERD, same thing. We don't know if this provider is following them or if they're just making a statement for who is following them. And then the ischemic heart disease, same thing. There's tests being ordered, and then we have pending labs. So quickly looking at it, for a for current E&M, it's a 99203. And nothing too earth-shattering here. When we look at it next year, we have an acute complicated injury. It's the rupture that needs to be repaired. Now look at the middle column. There were 2 tests ordered. You only need 2 of these 3 columns at the same level. So we can throw that piece out because we're in the moderate risk of morbidity from additional diagnostic testing treatment for this overall service. So this one could be a 99204. This is a 34-year-old female with bradyarrhythmias and cardiovascular review. As you skim through this note, symptomatic bradycardia, 6 sinus syndrome, pacemaker in place, device check indicated normal, cardiovascular, no, chest discomfort, suggestive of ischemia, patients denying orthopnea, PND, DOE, edema, not had palpitations, syncope, near syncope. So everything is denies, which is good. Cardiac history mentions the pacemaker. Now look at all these cardiovascular procedures at the bottom of the right left-hand column. We don't want to automatically give credit, just like today. Are these carry forward that the provider wants there, or are they reviewing them? So, you know, there's an EKG from June of this year. Oops, sorry, I don't know if that just got bigger on your screen. There, sorry about that. So we need to give credit for those that are current. Then we've got allergies, past history, lots of pages of fill in the clicks. And again, whatever providers say is relevant, that's what we want to have them include. Going over to impression and plan, 6 sinus syndrome, symptomatic, Patient has a permanent pacemaker. So that one's not, it's a chronic presence of the pacemaker, and function was normal. Mixed hyperlipidemia, well controlled. So these are things we're not seeing a lot of deteriorating or decline. Dizziness, maintaining sinus rhythm, all issues addressed. So there's not a lot of negative findings. The other thing is looking at encouraging checkup, follow exercise and diet plan, follow up in 1 year. So if we're going a year before we see this patient again, the fact is probably that they're pretty good health. So keep that in mind with your medical decision-making level. Bunch of stuff has been ordered. So looking at it today, we're at a 99214. When we move over to next year, we stay in a 214. We've got one or more chronic illnesses. We have ordering each unique test. There were 4 tests ordered. They can get credit for 2 for a category, or for, I'm sorry, 4. And then we have the moderate risk of morbidity. So this one across the board, 99214. No change from what they're getting currently. This is a female with a vaginal lump. This one, again, a templated note. We've got a health questionnaire. Remember, some of this is going to be quality measure related. We have history of smoking and vaping. No review of systems. We do have an exam. There is a mass, and in our assessment and plan assist, they're going to send them on to gynecology to work it up, and then encounter for screening and a BMI, which are likely tied to quality measures. This visit would back down to a 99213 because of that lack of review of systems. But the good thing is next year, we don't have to worry about that one element. The fact that there is no lab or x-ray won't affect the overall level of this visit, and it would actually support a 99214. Undiagnosed new problem, uncertain prognosis, and then the moderate risk of morbidity. I have one more. This one I have in here just because providers should be like jumping up and down. This is an 11-page note, and the bulk of this is, well, let's look. This was a patient who was here for neck and back pain. All of this templated carry forward information that has to be, dug through to find what's relevant. We do have some review of systems, which was pretty much negative, except easy bleeding and bruising. Also, the physical exam, very good, detailed. But our providers only have to worry about what they feel is relevant. We don't have to have, 8 met just to support the service. When we get to the assessment and plan, this one is great. It's pretty much the summary of everything that took place throughout the note. What I want to point out is on the top of the second column in the green box, I've spent time discussing with the patient, given prior surgery by another surgeon, there's a chance they would not offer the patient surgery, voiced understanding, discussed in detail. Provider mentioned twice in here the detail and the time spent discussing, but no mention of time was included. So this would be a great education point to say, right there, tell us how much time was spent, because you did discuss with the patient. And then it may bill at a higher level based on time instead of the medical decision making. So we continue on with lots of medications on the list. This was a 99204 under current auditing, and under next year's rules, it will stay a 99204. Again, it's a well-documented summary. We could use, like 8 or 9 less pages because we don't have to have all of that coming forward. Okay. Wow, I'm only 1 minute over. Any questions?
Brenda, you're okay. I think this actually gives you a little bit more time because we had till 1:30 on the website.
Oh, I'm sorry. I thought we only had till 1.
Nope, you're okay. So we have time for questions and discussion.
I see how many of you are in your masks, so you must be in the office. No questions?
If they want to unmute to ask a question, they can.
Certainly.
Yes.
Also, I did see somebody ask the question in the chat earlier, and I missed it if you answered it, so I apologize if this is duplicative, but someone had asked about whether you could still charge the 99211 for nursing visits. And I'm assuming the 99211 is going away completely. So what do nurses do?
No, 99211 does not go away. 99201 goes away.
The 201. Okay.
Yes. The 211 is still there.
Okay.
Do we know when which CMS is going to come out with reimbursement? Hopefully, sometime this month or next month. I mean, we're waiting. Can I mention something else off track of this? Since we have time.
Certainly.
If you guys are not aware, CPT or AMA released new codes yesterday for that's the wrong. Hold on, let me find the right one. For vaccinations for COVID, and there the codes. There will be 2 codes based on, there it is. Sorry, I got a pile of CPT assistants over here. There's going to be 2 codes for severe acute respiratory syndrome, coronavirus 2, COVID-19. And that one is a 30 mcg / 0.3 ml dose. And the other is for a 100 mcg / 0.5 ml. They're both intramuscular use. And then there are immunization codes 0001A, 0002A, and those will be used with the 30 mcg, the 91300 code. And then there's a 0011A, 0012A, that are the administration for the 100 mcg / 0.5 ml. And there's a code for the first dose and then another admin code for the second dose. There's also an Appendix Q that will be added. Now, for those of you that have your new CPT books, obviously none of this is in there. Well, it won't be in for any of us that are getting our CPT books. There will be an Appendix Q, and it will have, let's see, can I show you that? I don't know if you can see that very well or not. It will have the vaccine code, the administration codes, the manufacturer, the vaccine name, the NDC, labeler, product ID, vial, and then dosing intervals. So that 30 mcg will be a 21-day interval. The 91301, the 100 mcg, will be a 28-day interval. Yes, I can. I have about 4 slides that I just added to a presentation I'm recording tomorrow. I'll send those to you, Phil, and you can send them out.
Where can you access the slides? I maybe missed that. I didn't hear that on the call.
They are in the, go back up here. They're in the MGMA website. You have to be a member to access them. Am I correct? Phil or John or Abby?
That is correct.
Okay. And then I'll send these attachments after we hang up.
Under the MGMA Kansas website, you go, once you are logged in as your membership, you go to resources. Under resources, there's a tab for documents. And down at the bottom of the documents that appear, there is Brenda Edwards slide documents. You click on there and the E&M changes slides can be accessed there. If you once you access those, you can copy them. I mean, you can save them and distribute as you see fit.
Thank you.
Any other questions? Jill, I did not give a clear answer on the academic setting. I'm going to do some research on that because I don't want to mislead anybody. So I will follow up with that.
There was a question up there from Wichita Urology, Brenda. I don't know if you noticed it about CMS is going to come out with reimbursements. Did you answer that?
Yeah, hopefully sometime this month or next month. But one thing that I'm just going to put a shameless plug, Crossroad Health Resources, which I'm now a part of. I'm going to continue doing a hot topic tip sheet. So Phil, I can share that with you guys to distribute to KMGMA when we find that information out. If somebody doesn't find it out ahead of that, I'm happy to share that with you guys.
Okay, great. Okay, any more questions, anyone? While you have Brenda on the line? Well, Brenda, thank you so much for hosting another webinar with us and all the great information that you always share. We find your information so valuable.
Thank you.
So thanks again. And everybody, please don't miss Brenda's other upcoming webinar on the 2021 CPT updates. That's on December 3rd, and that's sponsored by Blue Cross of Kansas. Check the MGMA Kansas website for those events. I'll move on also and remind everybody that our very next webinar is on Thursday, November 19th. That's by Stephanie Moore on unconscious bias, invisible influences, lenses of bias that distort what's real. And that's sponsored by MedPro. Let's see here. And then also we have during the meeting or during the webinar, we did have the MediWaste partnership. We had another winner to the available memberships. We'd like to congratulate Joy Kilham, I hope I said that right, from McPherson Center for Health on becoming our second new member to take advantage of the $50 new membership. So congratulations, Joy. Okay, and that's all for today. So be sure to go to the MGMA Kansas website and look at the different headers and check out the events calendar, and then reach out to any of the board or contact us if you have questions.
Thanks, you guys.